I can shout. Thank you very much, Michael. It's a real pleasure to be here and start the discussions at this interesting symposium. And I would like to thank the Sheeta Company for allowing us to have these interesting discussions, which will largely call on personalized medicine, which is something that we should all be enthusiastic about. There are no simple protocols based on formula that will work in intensive care medicine. We need to individualize our therapies. It works now? Can you hear me? Yeah? Yes. Otherwise, I will speak louder. When we give fluids to an acutely ill patient, we would like to see a positive response in terms of an increase in cardiac output. And in the hypotensive patient, it may translate into an increase in arterial pressure. Now, what we don't want to do, of course, is to have an increase in hydrostatic pressures that would result in edema formation. Edema is never good for any organ, the lungs, the kidney, the brain, the heart, whatever. The organs do not like to be edematous. So before we give fluids to a patient, we must identify a problem that may be alleviated by fluid administration. The problem may be hypotension, it may be tachycardia, it may be decreased urine output, it may be altered skin perfusion. We must identify the problem. It could be a combination of abnormalities, of course. And when we indeed stop to give fluids, because that will be the important message of our talks, I'm sure, we need not only to know when to start, but we also need to stop when there is no major benefit, or when the risks exceed the benefit, or of course when the problem is resolved. Seems natural, but sometimes we continue to give fluids and we forget about stopping it. So we would like the heart to pump a higher cardiac output. We don't want the cardiac filling pressures to increase, as this would result in greater edema formation, especially if the capillaries are leaky, especially if there are permeability alterations. So to my students, I compare it to a restaurant. When you go to a restaurant, you order food and drinks, but you know they will appear on your bill at the end of the meal. So if you enjoy it, if you eat it, if you drink it, it's fine. But if you order a dessert and then you say, after all, I don't want a dessert, well, that's stupid, because you will pay for it and you don't benefit. And it's the same thing with fluids. We would like to maximize the benefit, minimize the unwanted effects. We want to maximize the increase in cardiac output and minimize the increase in cardiac filling pressures. Physiologically, that's what creates edema. That's filling pressures. So, once again, but it's fundamental, we need to identify a problem. And low cardiac filling pressures, of course, is never a problem. I hope that as a healthy individual, I have very low central venous pressure, very low pulmonary artery, capillary wedge pressure, if we had to measure it. I hope, because that's the way it is. Don't say, so we won't give fluid. Oh, no, because if you keep a patient on vasopressors for hypotension without giving fluids when the patient may benefit from fluids, that's the road to multiple organ failure. And that's how we developed several years ago, and now we use this SOSD scheme. Salvage, we want to keep the patient alive. We open the bottles, we give vasopressors, it's a matter of life or death, then we optimize. But once optimization is over, when the patient no longer benefits from further fluid administration, we are reaching a stabilization phase. We should stop giving fluids. And the patient then should eliminate it, otherwise the patient will remain like this. Now you may say, echocardiography is wonderful. I agree, and you don't need to be an expert. If you don't know how to do it, come to Brussels in November and you will have the expert there who will show you how to do it with the transmission of images from the ICU into an auditorium like this one. You can interact with the experts. Okay, but echo is not everything, I'm sorry. And especially if you want to look at changes in size of the vena cava. For the inferior vena cava, as you can see in this meta-analysis, it may not work so well, actually. In some studies, yeah, in some studies, not so well. If you want to go to the superior vena cava, as Dr. Vignon reported recently in the American Journal of Respiratory and Critical Care Medicine, it's not great, but it's better. It's not great, as you can see on this rock curve relating sensitivity and specificity, and yet the patients were sedated and even paralyzed. So even in the best conditions, it may not tell you everything. So in the optimization phase, we may need something else than echo Doppler studies. Central venous pressure assessment, SCVO2, cardiac output, signs of fluid responsiveness, fluid challenge. If you think about it, these are the things you may consider. Yeah, we may still be invasive. These are the latest guidelines on the management of septic shock in children. In children. They recommend it in patients who do not readily respond to fluids to insert a central venous catheter in children. And then look at changes in mean arterial pressure and central venous pressure and look at the difference between the two. If indeed the CVP increases more than the mean arterial pressure, stop. If you keep the same gradient, you may continue. So I think there is still a place for invasiveness today. Maybe not in the future, but today there is still a place for it. And don't tell me that the CVP doesn't mean anything. I mean, any hemodynamic variable means something. If you have a patient with recent diarrhea, having a low CVP, don't tell me, it doesn't. Now, it's true that when the CVP reaches medium ranges, from a single static value, you cannot say very much. Except, again, that statistically speaking, when it's quite low, the patient is likely to respond to fluid administration. But when the CVP is relatively high, you don't know. You need to test the system in a dynamic way and see whether cardiac output will increase or not. So indeed, in this paper already old on fluid challenge, we say you should never use a CVP as a goal. Give fluids until CVP reaches that value. It's like going to a restaurant and say, okay, when I reach my 50 euros here, I stop ordering anything. It doesn't make much sense. So why would you aim for a given central venous pressure? And that's how with the Surviving Sepsis campaign, we suggest to use dynamic rather than static variables. Static variables being either a given CVP or a given end-diastolic volume is the same thing. You need to look at it in a dynamic way, changes in CVP or changes in some variables during the respiratory cycle. And of course, when you try fluid, optimally you should measure cardiac output and see whether cardiac output increases or not. So that's the way it is with the fluid challenge. But if we could have a good way to predict fluid responsiveness, that would be great. And that's what we are here together this afternoon. And others will explain how in mechanically ventilated patients we could look at pulse pressure variation, stroke volume variations, but there are also some limitations, but I don't want to go over what the others will say. Passive leg raising, very interesting, but it's not so simple. I just raise the legs, as Jan-Louis and Xavier Monet emphasize. It's not just looking at blood pressure. You need to look at stroke volume during the passive leg raising. Very important. And importantly, whether it's the fluid challenge or the prediction of the response to a fluid challenge, it would help you more to stop giving fluids rather than encourage you to give more fluids. I repeat, this is very important. These techniques will primarily help you to stop fluid, not ordering the dessert when you are no longer hungry. Stop! Instead of encouraging you to give more fluids. So, what is the future? You may have read it. It just appeared in intensive care medicine. I was invited with two guys of my age who are a little bit older, Art Slutsky and Gattinoni, to say, what will the ICU look like in 2050? And we said, you know, we will no longer be here in 2050. Maybe I will, but not the others. And, but we could have a child in an ICU, and our child could tell us how it is. And very briefly, our child could say, you know, when I was in shock, it's, I took the wrong slide. I took the wrong slide. When I was in shock, I'll see if I have it for you. Otherwise, I will tell you what this represents. When I was in shock, voila, I can see it. When I was in shock, I was told that my bed was moving, and there was a system that would evaluate whether I need more fluids or not. And I really believe that that's the future. Actually, we spoke about it at another session. I don't remember which one, but we said in the future, you know, in the bed, we may actually have changes in position, passive leg raising. The bed could go by itself in a different position. And then we could look at changes in stroke volume during that test. And of course, we could either push on a button or it could be done automatically. So that's how I see the future. But of course, we should not do it in every single individual at all times. No, of course. It's only, once again, when there is a problem that could be alleviated by fluid administration, like often hypotension in most cases, or tachycardia, oliguria, altered tissue perfusion. So, in summary, there are some patients who obviously need fluid. They are bleeding, they are coming in with recent gastroenteritis. You know that they will benefit from fluid. But if we don't know, if they are mechanically ventilated, sedated, even paralyzed, we could look at pulse pressure variation, stroke volume variation, but we try to avoid much sedation and paralysis. So the passive leg raising test is very appealing, but it's not so simple. I think we are moving along the evolution of the test. And we need to make progress in making it more feasible at the bedside and more simple than it is today. And it's not just looking at blood pressure. We need to have an indicator of flow, and that's what we will discuss during this symposium. But keep in mind the 4 phases of salvage, optimization, stabilization, and de-escalation. And remember, the idea is not so much to know when to give fluids, but when to stop giving fluids because it's no longer beneficial and no longer needed. So we need to work along these lines to make our systems better and easier to apply at the bedside of the acutely ill patient. Thank you. Vielen Dank.